Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc to Doc podcast.
Hello, I'm Steve Hoth, a board-certified cardiac and thoracic surgeon at Baptist Health Miami Cardiac and Vascular Institute. I specialize in adult cardiac surgery, and I'm a fellow of the Heart Rhythm Society.
How you doing, Steve? This is Dr. Mario Pasquale here. I'm an electrophysiologist at Miami Cardiac and Vascular Institute, and I'm here with Steve today to talk about inappropriate sinus tachycardia.
So let's go ahead and get started. As Mario suggested, we like to talk about an unusual and often underdiagnosed arrhythmia, that is inappropriate sinus tachycardia. We'll discuss the clinical scenario, including demographics, symptoms and presentation, initial evaluation, medical therapy, as well as catheter-based and hybrid therapies for this syndrome. So Mario, let's start with the clinical scenario. If you can describe to our listeners your initial meeting with someone with a suspected diagnosis of inappropriate sinus tachycardia. What's the typical patient population and what symptoms are you looking for?
Yeah, Steve. So inappropriate sinus tachycardia, I think, can be, first off, a very frustrating diagnosis for, patients and their families, and sometimes can be quite frustrating for treating physicians because it is something that can be difficult to diagnose. It is something what we call a diagnosis of exclusion, meaning you have to exclude many other causes before you get down to what is causing the patient's symptoms. And most commonly, what patients will complain about is that they just feel like their heart is always racing. Meaning, for me and you, I think probably if we get in some type of stressful situation or we go out and start to exercise, it's normal for our heart rate to kind of accelerate. These patients, minimal things, just such as walking to the bathroom or even trying to go to bed at night, they will feel their heart kind of racing and just going extremely quickly. And so when they first present, they just feel extremely poorly because things that should be pretty easy to do, such as walking around the house or going up a flight of stairs, are very difficult to do because their heart rate is just extremely high.
So from an electrophysiology standpoint, can you describe to us the abnormality as we understand it that's typically seen with inappropriate sinus tachycardia?
Yeah, so most of our patients are usually young patients, and it's much more common in young women than in young men. I would say the first part of inappropriate sinus tachycardia and trying to explain it is, like we said earlier, just ruling out any of the causes of what we call a physiologic or reflective sinus tachycardia. And these are what we term a lot of metabolic causes. So we make sure, number one, that the patient has, no signs of any type of metabolic issues, such as anemia or hyperthyroidism, which can definitely increase the heart rate. We make sure the patient, is not on illicit drug use or has a diagnosis of anxiety disease or some type of underlying lung disease, which can certainly, accelerate a patient's normal heart rate. Also want to make sure the patients are not on any stimulants. Patients with inappropriate sinus tachycardia, especially any type of stimulation, such as even just any type of coffee, will definitely increase their heart rate. So, we want to make sure and rule out any type of metabolic cause that can cause increase in, a patient's average heart rate. Now, in patients with inappropriate sinus tachycardia, when we get down to the pathophysiology and the causes, the truthful answer is that we don't fully understand the mechanism or the pathophysiology of inappropriate sinus tachycardia. There is a lot of data and, there is a lot of research being done. We think that these patients' sinus node, which is kind of what determines a patient's, average heart rate, is just extremely sensitive and extremely labile to minimal, sympathetic inputs into the heart. And so when we start talking about targets for treatment, we not only target the sinus node, but we have to kind of think about where are these sympathetic inputs that are innervating the sinus node and causing the sinus node to go quite fast. My initial workup for these patients will be, of course, ruling out those metabolic causes, but secondly is getting some type of prolonged monitoring, whether that's a 48-hour Holter monitor, 2-week Holter monitor, 30-day monitor. And what we're trying to understand is, what is this patient's heart rate doing over that time period? The very strict definition of inappropriate sinus tach per the Heart Rhythm Society will be anyone whose average heart rate is above 90 beats per minute. And of course, that's quite, a subjective cutoff of 90 beats per minute. So it doesn't always have to be exactly at 90 beats per minute, but that's certainly where the differentiation between inappropriate sinus tachycardia and maybe appropriate sinus tachycardia is made. We always do some, lab work and assure that there's no other signs of causes of their sinus tachycardia. And we also want to make sure that a patient's heart is structurally normal. It's interesting that any type of other arrhythmia, such as an atrial tach, which can be confused for inappropriate sinus tach, if it's incessant enough, can lead to what we call a tachycardia-induced cardiomyopathy, where their ejection fraction can drop just from how fast their heart rates are. In patients with inappropriate sinus tachycardia, it is quite rare and almost never reported for these patients' ejection fraction to drop. So despite their average heart rate being 90 beats per minute or well above that, the fact that they have a cardiomyopathy will actually lead us away from inappropriate sinus tach and likely towards some type of atrial tachycardia coming somewhere from very near the sinus node.
You've described to us, kind of the initial evaluation. And so, you see this patient in the office and, get the laboratory studies and make sure they don't have, thyrotoxicosis or pheochromocytoma or some other really weird cause for higher sympathetic tone that could lead to some of this. What would be the first round of medical therapy if you're pretty convinced that this patient has a diagnosis of inappropriate sinus tachycardia, ruled out all the other things that you talked about? What's the first line of medical therapy look like for these patients?
Yeah. So I'll tell you, the first thing I tell all these patients is that the management of IST is going to be tough. And it is tough. I think it's tough and it's frustrating because the patients just feel so poorly, but their input into their treatment is extremely important. And they have to kind of be willing to push through some of their symptoms. So the first thing is we set expectations. We talk about the avoidance of triggers, common triggers being, stimulants, caffeine, and dehydration. So we talk about the importance of hydration. We talk about the importance of psychosocial support. We talk about the importance of having a good exercise regimen. So even if they feel poorly, just kind of pushing through, again, talking about that attempt to really decrease the sympathetic tone. And one thing that patients with inappropriate sinus tach have a lot of its sympathetic tone. So if we can get these patients into establish an exercise regimen, we can have that sympathetic surge during exercise. We're hoping that their parasympathetics input will improve and they will feel much better. Many patients, at least at first, will definitely need to be started on some type of medical therapy. And that's where we talk about what we call SA nodal slowing agents, beta blockers and calcium channel blockers. And so we would start the patient on low doses of SA nodal slowing agents like beta blockers and calcium channel blockers. The problem with these medications is a few, and that is, all related to side effects. As we talked about earlier, a lot of these patients are young females. And as you know, young females tend to have very low blood pressure. So you add any type of low dose beta blocker or calcium channel blocker to these patients, and all of a sudden they're feeling much worse than they were even without medical therapy. But we try to talk to them about starting medical therapy at low doses, having them kind of come up with their own titration parameters to see if they can continue to increase the dose on their own. And then we talk about all the other things, hydration and avoidance of triggers. But as you know, many times we fail, and that's where we kind of start to discuss the next step with these patients.
So from a medical standpoint, the first line of therapy would be a class 2 or class 4 drug. Tell us a little bit about the role of Corlanor as it pertains to the medical therapy of IST.
Yeah, so Corlanor is kind of the new guy on the block, although it's been out for several years now. Initially, Corlanor came about in patients with heart failure. And so the SA node, the sinus node, has a channel involved that's called the funny channel. And this funny channel is actually the channel responsible to depolarize and cause activation of the sinus node. And so Corlanor was kind of designed to block this funny channel. So in patients with heart failure, we know that if you can decrease their mean heart rates, they'll have a decreased risk of recurrent hospitalization, their functional status, and they'll feel significantly better. And so once we saw that it worked for heart failure patients, whereas decreasing their average heart rates by about 10 to 15 beats per minute, there was a lot of interest both in the US and predominantly in Europe, where they started to use Corlanor in patients with inappropriate sinus tachycardia. The beauty of Corlanor is that certainly doesn't drop your blood pressure. So in these young females who have kind of low blood pressure at baseline, Corlanor is usually much better tolerated. So we start Corlanor at a very low dose, which is 2.5 milligrams twice a day. And every 2 weeks, we start to go up to a max dose of 7.5 milligrams twice a day. And it is kind of the one medication that I can see that patients tolerate and patients actually feel better on than worse, like they so often do with beta blockers and calcium channel blockers.
And if you have a patient that's on Corlanor that you think has a diagnosis of IST, what's been your experience with the success of that in say, an intermediate term basis?
Yeah. So I think, pretty good success in the sense that, patients will feel better and their average heart rates will drop. Our biggest problem with Corlanor is it's not yet approved in the United States for patients with inappropriate sinus tachycardia. So our biggest problem is having patients who can actually afford the medication and, getting it approved by the insurance companies. So if we can get kind of through that bureaucratic process, I'll tell you, patients feel significantly better on it. But many times it's tough. Patients get frustrated and there's a lot of out-of-pocket costs. So I think that's the biggest challenge. If you have a patient with pure inappropriate sinus tachycardia, and we won't get too much into this, but there is certainly a spectrum of disease in patients with inappropriate sinus tachycardia. So if they have that spectrum where they also have episodes of near syncope or syncope, Corlanor is not going to be as effective for those patients. But for your pure IST, I'll tell you, we're seeing some nice results with it.
So it sounds like then Corlanor is probably the drug that may have the most hope down the line for being able to treat, at least in the intermediate term, patients with inappropriate sinus tachycardia. You and I have certainly seen patients that have failed Corlanor, and whether it be for financial reasons or clinical reasons. And we've had lots of conversations over time about more advanced therapies. And I think that's one of the things that a lot of patients with this disease process have looked for. So tell us a little bit about what you've seen and what you know about the catheter-based therapy for this in patients who have failed medical therapy and continue to have symptoms, and the pluses and minuses of catheter-based therapy for this problem.
Absolutely. And I think one of the things I didn't mention before is, again, these are young patients. And even if they respond to Corlanor, just the idea of being on medications for 10, 20 years, especially if you have a young woman who's interested in becoming pregnant, it's just not ideal and something that patients get a little frustrated about. And, as an EP community, we began to look at catheter-based ablation strategies for inappropriate sinus tachycardia. And so similar to other ablation strategies, this involves getting access in the groin, putting up some catheters into the right atrium, and then studying the exit of the sinus node. And so we would map and see exactly where the sinus node exit was, take a different catheter, what we call an ablation catheter, and ablate this area in order to change the exit. So if we can modify the sinus node enough, we can take a patient whose average heart rate may be 90 beats per minute. And if we kind of ablate enough of the sinus node, we can hopefully decrease the activity of that sinus node and decrease their heart rates into the 70s. The problem with our procedures, Steve, I'll tell you, is that, as you know, the sinus node is not just one small node that sits in one small area, but instead it's a kind of cluster of cells, or crest, we like to call it a sinus node crest of cells, that kind of involves, comes down from the SVC towards the anterior lateral aspect of the right atrium. And many of the inputs that, go into the sinus node are actually not inside of the heart or endocardial, but actually they're epicardial. So in order to do a good sinus node modification from the endocardial site, we're having to do a pretty extensive lesion set. And unfortunately, this led to approximately 30% of patients requiring a pacemaker after an endocardial ablation, just because of the extensive ablation which was required in order to have a therapeutic effect in these patients with inappropriate sinus tachycardia. And as you know, just a 30% pacer rate in this young patient population was just too high. So there was some interest in kind of how do we ablate inappropriate sinus tachycardia without actually ablating the sinus node and decreasing that. And I think that's where, this kind of hybrid ablation idea began. And I'll push it back to you so you can kind of give a little bit of the history on there.
Yeah. Happy to do that. The other thing that I've run into in my experience, and comment on this if you like, is the second thing that we saw in patients who had previous catheter ablation is, as you described, it often requires a fairly extensive endocardially based ablation to get that epicardial structure. And one of the other anatomic structures that's in the neighborhood is the right phrenic nerve, which runs right in that area. And so one of the things that we've seen in the past is a few patients who ended up with the right phrenic nerve palsy. Mm-hmm. And that ends up being adding a separate problem. Now they're a little bit short of breath because their right phrenic nerve isn't working very well. So as you know, those are both challenging things. And so with the frustrations of, relatively few pure catheter-based advances, some of our friends in Europe began working on ways that they could more safely ablate the SA node complex and do it without injuring the sinus node and doing it without injuring the phrenic nerve. And so that ablation experience was based a lot on their experience with ablating AFib, which uses similar devices, but now we're targeting different structures. And so the hybrid procedure that was developed and is, I think the group in Brussels is, our friends in Brussels are probably the world's experts at this, have reported this, and we can talk about references for our listeners a little bit later if you want. And there continues to be some modification of this technique, but basically ended up with a technique that includes it's basically a same-day hybrid procedure where catheters are placed through the groin area, as you described, for an endocardial procedure, but it's also done with a right thoracoscopy procedure, so 3 small incisions along the chest wall to allow the patient who is asleep at the time to have their right lung deflated so we can see their heart, and basically open the protective heart sac, and that exposes the lateral wall of the right atrium that you described. And with some dissection to free up these areas, they've created a set of ablation lesions that include the SVC and the IVC as what ends up being exit points for that ablated SA node complex, and then the SA node complex as well. And the structure that they like to talk about that sits at the very end of that SA node complex is a structure called the crista terminalis. And so that's oftentimes the focus for this sort of an arrhythmia that they've seen. And so the nature of the hybrid procedure then ends up being, starts with a catheter procedure that you've described, that allows us to try to map and see if we can find the area of earliest excitation or initiation of the arrhythmia. So we map that focus as well as the SA node focus. The latter is important because we want to stay away from the SA node. As you have described, one of the things we don't want to do is modify the patient's SA node. So this technique that was described by our friends in Belgium is a node-sparing ablation procedure that then, so once those initial mappings are created, and as you and I have done in the lab, the way we do that is once you see the SA node, I actually put a little mark on it. And so that's, the no man's land right there. And so that's what we want to protect at all cost. So, and again, with varying varying order, we'll ablate in 3 different areas. So we'll ablate that lateral wall of the right atrial wall that includes the crista terminalis, and then connect that with a lesion set in the superior vena cava and the inferior vena cava. That's the surgical lesion set of this hybrid procedure. Then we'll go back with catheters and we'll look at those ablation lines and try to, remap, sometimes even try to induce the tachycardia. And as we're doing those surgical ablations, we're actually looking at what the heart rate is doing. And it's remarkable to see, instantaneous drop in heart rates. We're careful to avoid heart rhythms where the SA node has been damaged. And we sometimes see that transiently, a junctional rhythm or a nodal rhythm. But we're always cognizant of those sorts of things. And so we'll go back and I think the subsequent mapping really does 2 things. The first is it tries to induce tachycardia. The second is to be sure that the lines of ablation are robust, because we've certainly seen times where the lines of ablation may not be complete all the way from one end to the other. And as we've learned with ablation strategies for atrial fibrillation, I describe lines of ablation that we're trying to create scar on the heart to interrupt abnormal conduction, as the analogy that I use for patients is a little bit like building a corral for wild horses. Right, if you leave a couple of gates open or a couple of fence posts too low, ultimately the little buggers will figure out a way to get out. And the same is true with electricity. So that subsequent catheter-based mapping is about making sure that the lines of ablation are complete. And if they're not, with the the beautiful GPS-driven devices that you've got, you can find those little spots and close those gates or raise those fence posts, so we can be assured that the patient's going to heal with a nice complete ablation line and have good success. And that's what we've seen in the past. And that's a procedure that takes, a couple of hours, maybe entirety to do. We keep people in the hospital for a couple of days after that, and then they're pretty much kind of back to what they're doing. But our experience with that procedure has been extremely effective if we do a couple of things, and that is, as you described before, the most important thing is to find the right people. This operation is designed to fix what we think is a specific abnormality in the sinus node complex. But if you don't have that abnormality, it's not going to help you. And so making sure that we pick the right patients is really, really important. And if we do, our success rate and the success rate of our friends around the country and around the world that do this has been really quite excellent. And so I think we've been really gratified by the response that we've seen. So anything that you want to add to that description of the hybrid procedure?
Yes, I think I'll just, agree that it's incredible how immediate we see drops in heart rate. And as soon as you kind of clamp that area of the SVC, right atrial junction, you see that immediate drop in heart rate of almost 30 beats. And it's just incredible. And, again, we don't understand the full mechanism of IST, But just seeing that as soon as you grab those epicardial inputs, you have a drop in the heart rate of about 30 beats per minute, just makes you a believer that it's not the sinus node automaticity itself, but just these sympathetic inputs that are just, very aggressively going into the sinus node. And, yeah, we do have to touch up a little bit after you're done with your ablation lesion. But I think we also know, where the vast majority of the reconnection is, because like with any procedure, there's going to be some areas that are very difficult for me to get to and very easy for you to get to. And there's some areas in the heart that are very, very difficult for you to reach and a little bit easier for me. So, it's almost, we certainly recheck the work. But I'll tell you, it's very few times where we'll have to go in and do a much more extensive lesion, because you guys do such a good job of ablating from the epicardial side.
Yeah, I agree with you. It's a team sport. There's no question about it. And when we're talking about these sorts of complex arrhythmias, whether we're talking about complex forms of AFib or IST, I think we've found tremendous success in this hybrid approach, this team approach. And the other thing that I'll mention about the hybrid approach itself is the second of the two problems that we sometimes see with the catheter-based approaches, and that is right phrenic nerve palsy. And the beauty of this sort of procedure is, well, it means going through a thoracoscopic procedure. As soon as we open that pericardium and the protective heart sac there, we can actually retract that phrenic nerve out of the way. So now it's not even in the area code, and it's just not something that we worry very much about. And so if we're protective of the SA node and with the right phrenic nerve retracted away, that relieves us of really the two biggest problems that I think we sometimes see with catheter-based therapies. And that's not to say that catheter-based, you and I both have seen successes with catheter-based therapies, but there's been some frustration. So I think having all those areas in our quiver is a really important thing. The last thing that I thought we might touch base on is the research that's going on to try to, continue to move the treatment of this disease process forward. And so there is a clinical trial currently enrolling called the HEAL IST trial. It's basically, a formalization of the hybrid approach that we've talked about in patients who have failed medical management and still have symptomatic inappropriate sinus tachycardia. This is a trial that has been in the works for a couple of years, and now we're probably, worldwide, at least a year, maybe more into enrolling patients. There are currently 22 sites in the world, 19 in the US and 3 in Europe that are enrolling patients. As I said, here at the Baptist Health Miami Cardiac and Vascular Institute, we are one of those sites, and we're extremely grateful to be involved in that research trial. Some of the patients that we evaluate, I'll say honestly, don't meet the criteria for that trial because the definitions of IST, just in order to be really fastidious, are very difficult to achieve. And I think this is a disease process that has a little bit of a spectrum. And so we certainly have treated people outside of the trial, but are delighted to talk to people, everybody that we talk to, about possibly enrolling in the trial. And the trial really is just a matter of quantifying risks and outcomes. It's about standardizing procedures. Patients are treated the same worldwide, and then are followed for a significant period of time to see how they do, and with the hope that this will lead to FDA and Euromark approvals and insurance approvals and things like that, to really be able to offer that to more patients. So anything that you'd like to add to what we're doing with HEAL IST or other research efforts that have to do with IST?
Steve, I think you summarized it well. And I think, the beauty of the HEAL IST trial is really giving patients an option to manage this disease, which once again can be very tough and can be difficult to treat. And I think having, more data to prove, how effective it is, or maybe not. That's part of the research trial. We got to make sure we're doing the right thing for patients, but I strongly believe that we are. And this research trial definitely gives us a great option for our patients.
So we've been very fortunate to be able to be involved in that trial, and have had, several years of experience doing this. Wanted to just kind of wrap it up with some final thoughts. You've heard me tell this story before, and I'll tell again for our listeners, and then I'll ask you for some of your comments. I think that this is a very challenging diagnosis to make for people, but for the people that have it, the patients that I've talked to are equally frustrated. I believe that in the patients that we choose appropriately, this hybrid therapy that we talked about has been very effective. And I tell people that, while it's not been universal, it's been one of my common experiences that these women cry twice in my office. The first time they cry is when they come in and tell me how crummy their lives are, how disruptive this has been and how difficult it is to, keep regular routines, and sometimes to how it impacts relationships, jobs, and things like that. And the second time they cry is when they come back and they feel so dramatically better after an ablation procedure. So I'll be interested in your final thoughts, and we'll wrap this up.
Yeah, no, agreed. With these patients, it's truly a process. And I think, one of the best patient relationships you can have is patients with inappropriate sinus tachycardia, because you lean on each other. And again, a physician can't cure this disease without the active participation of the patient. And so the physician-patient relationship is so important in order to have our best success in inappropriate sinus tachycardia.
Yeah. So the last thing I'm going to leave with our listeners is a citation that I think is very important, that was published in the Journal of the American College of Cardiology in 2022. The primary author is a gentleman, electrophysiology, a buddy of ours named DJ Laccaretti, works in Kansas City. And the title of the paper is Inappropriate Sinus Tachycardia, Etiology, Pathophysiology, and Management. And I think it's a great summary of this complex disease process. And for those that are interested in some additional information about the disease process and the treatment options, I think that's a great resource. So Mario, really appreciate your input in all this, and your support and your friendship as we've gone down this road. And we look forward to doing more of these podcasts in the future.
Absolutely, Steve. Thanks for inviting me, and always thanks for hosting it. And this is always a lot of fun, so I appreciate it.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.